I'll be presenting a case series of febrile retinitis associated with macular edema from Western Orissa. These are my acknowledgements. So post-fever retinitis can occur after viral or bacterial infections like dengue, typhoid, chikungunya and rickettsia. It presents usually after 2 to 4 weeks of the onset of fever. Presents with mild vitritis, multifocal retinitis, retinal hemorrhages, macular edema and disc edema. Pathogenesis, although not clear, could be either parainfectious or immune-mediated mechanism or a mixture of both. Although no standard treatment has been described for this entity, we can use oral antibiotics and oral steroids. So we enrolled all the patients presenting with retinitis and macular edema with a recent history of fever between January 2021 to December 2022. A comprehensive ophthalmological workup was done, including fundus photo and OCT macula. Serology reports from previous health checkup were obtained. And we did all the routine investigations like CBC, ESR, ELISA, MANTU, chest X-ray, along with some special investigations like dengue, well Felix for rickettsia, viral chikungunya, and MPICT. Macular edema was defined as the presence of either subretinal or intraretinal fluid or central foveal thickness of more than 300 microns. A resolution was defined as a complete absence of subretinal and intraretinal fluid and foveal thickness of less than 300 microns. We excluded patients with fever, with sepsis, media haziness like mild vitritis or cataract and other systemic illnesses like diabetes. And all the patients were given oral doxycycline of 100 mg BD for 7 days along with oral steroid at 1 mg per kg body weight along with topical steroids in a tapering manner. They were followed up after 1 month and then 3 monthly up to 12 months. So coming to the results, we had a total number of 18 patients and 27 number of eyes, and our mean age of presentation, we found that it was 32 years with a male preponderance. Out of 18 patients, 11 had serologically positive with the highest number showing typhoid positivity followed by dengue, malaria and rickettsia. We also found that there was a seasonal variation with most of them presenting between September to March with a peak in February. Coming to further results, we saw that the eye involvement was invariable, duration of vision loss was around 9 to 10 days, history of onset of fever was around 4 to 5 weeks, and OCT showed subretinal fluid, intraretinal fluid and hard exudate in almost all the cases. Outer retinal layers atrophy was found in one case. Macular star during presentation was present in 51.9% of the cases. However, 85% of the cases showed macular star developing during follow-up. So coming further, we saw that the OCT showed a resolution of macular edema starting from 803 to 186 by the end of 5th follow-up, and the corresponding visual acuity also improved. And this shows a linear relationship between OCT and the logMAR vision at each visit. Coming to the cases, this is one of the cases who had retinitis along the superior arcade and a small retinitis patch along the inferior arcade with macular edema and neurosensory detachment. Corresponding FFA showed disc leakage and vascular trunk leakage along with some block fluorescence due to the hemorrhages and CNP areas. So this is another case who had bilateral involvement and there was development of this macular star during follow-up. So we saw that there were different anatomical subtypes as well. They may occur along the arcades or may involve the posterior pole, maybe peripapillary or a mixed variety. Recurrences, yes, there was recurrence in one of the cases. Along the inferior arcade, the retinitis patch has increased during the course of follow-up. However, macular edema recurrence was not there. Our limitation was that we could not use a wide-angle fundus camera, so we could not document any lesions outside the arcades. A large number would have been helpful. So, in conclusion, macular edema is a common association of febrile retinitis, and visual improvement resolution of retinitis and macular edema can be achieved with oral doxycycline and steroid tablets. Macular star pattern is a common finding and different subtypes need to be studied in order for prognostication. Thank you.
Thank you. Nice presentation. Did you have some control groups also? You said with the doxycycline and steroids. So When did you give doxycycline in all the patients
Yes, sir, we did.
and steroids also in all
Yes,
the
sir.
patients?
Yes, sir.
So this was empirically given actually.
Empirically given, yes.
Did you look at the compare the control group?
No, sir, no, sadly we don't have
That
a
would have been better
Yes,
so
sir.
that you can say whether anything needs to be done or not.
Yes, sir.
Or this is self-resolving.
Yes, it is considered to be self-resolving, but since we come
Then
from
we don't
Western-
need to give
Yes, sir.
doxycycline steroids specially.
If macular edema is not there is no macular involvement, then probably we can just observe. But if there is macular involvement, then we can start epical therapy.
But in your study, you have given doxycycline
Yes, sir,
steroids
because all
to
of
each and
them-
every patient.
Yes, sir. Yes, sir.
Macular edema or no macular edema, retinitis needs to be treated.